Good morning, afternoon, and evening to everyone. Welcome to Global Insights, a live interactive panel discussion which sheds light on big questions currently facing policymakers, planners, and researchers worldwide. Global Insights features experts from leading schools of international affairs, including the Balsillie School in Canada, the University of Konstanz in Germany, the American University in the United States, and many other partners. Today's live stream production is entitled Vaccines in a Vaccinated World. My name is Anne Fitzgerald. I'm the director of the Balsillie School, and I'm delighted to be moderating today's session. A warm welcome to all participants in the audience. If any of you would like to direct a question towards our panelists, and we would invite you to do so, we will do our best to channel those questions to the appropriate panelists, especially towards the latter part of the session. Before we begin, I'd like to start with a land acknowledgement. For those in the audience who are tuning in from outside of Canada, one of the actions we take to advance reconciliation between settler and Indigenous peoples is to reflect on our relationship with the land and the continuous process of colonization that deeply impacts our work. The Balsillie School is proud to be situated on the Haldimand Tract, the land promised to the Six Nations, that includes 6 miles on either side of the Grand River, which is on the traditional territory of the Attawandaron, the Anishinaabe, and the Haudenosaunee peoples territory. It is particularly important that we here at the school acknowledge this land on which we are situated in all that we do, including Global Insights. To start us off with this morning's conversation, let's turn to our distinguished panel. Liliana Abreu is a postdoctoral researcher at the Development Research Group, Department of Politics and Public Administration at the University of Konstanz. Her research interests and experience focus on behavioral studies, social epidemiology, and more recently on the impact of social adversity experiences, namely violence and trauma, on social causes of mortality and morbidity. Maria de Jesus is an associate professor at American University's School of International Service and a research fellow at the university's Center on Health, Risk, and Society. Her research areas of expertise are global health inequities, immigrant and migrant health, and culturally responsive and effective health communication. Alan Whiteside is a professor at Wilfrid Laurier's School of International Policy and Governance and at the BSIA. He is a member of the Governing Council of Waterford Calabar United World College in Swaziland. In 2015, he was invested as Officer of the Order of the British Empire. Dr. Whiteside's current research program focuses on interrelated areas of global health concerns. Thanks once again to all the panelists for joining us today. I think it's safe to say that vaccines are at the top of everyone's mind these days. And the fact that we even have vaccines so quickly is an incredible and unprecedented achievement. But before we begin our discussion today on the politics of vaccine rollout and vaccination, I'd like to start with a lay of the land in respect to the vaccine situation. Alan, how many vaccines were in development and how is it decided which ones will be approved and distributed?
Okay, well, I think we just need to go back a bit to the on the virus and just remind ourselves of 3 key points which are necessary to have in our minds as we talk about vaccines. The first is that this is an easily transmitted, and it's transmitted as an aerosol, which means it lodges in our tracheas and our lungs. And people can infect other people before they know they're infected. And that is what makes this epidemic unique, is the fact that people can go around infecting others without knowing. Normally we get a fever and isolate ourselves. Second thing is that most people experience a mild illness. 17% need care, and the case fatality rate can be as high as 14.5%, which it was in June in Italy. In Canada, it peaked at 8.6%, and now it's 2.6%. And third, prevention is the key. And this brings us to the vaccine issue, because up until quite recently, we were looking at other forms of prevention, which was around isolation, around mask wearing, and sanitation. So vaccination is the most effective form of prevention. And as soon as the Chinese released the genetic sequences, scientists around the world began the race to find a vaccine. And this is a race where there can be more than one winner. So directly to your question, in June 2020, there were 125 vaccines in development around the world. Today, there are 10 serious contenders. There may be others who come in, but I don't think there are going to be very, very many, because we've had a major winnowing out of who's in the business of likely to succeed. Two major initiatives in the US, Operation Warp Speed, and in the UK, Operation Moonshot, both with major public money and support. And the leaders are Pfizer-BioNTech, which has approval, regulatory approval in the EU, the US, Canada, and the UK, and it's been rolled out across the world. This is the one which has the problem because it has to be stored at -70. The Moderna vaccine, approved by the same countries. AstraZeneca, which is the most recent to be approved, and it's approved in the UK, India, and the European Union. And pending in the West, we have two others, Novavax and Johnson & Johnson. Johnson & Johnson is the one which tempts me the most because it's a single dose. We also have 3 Chinese vaccines, which don't have to go through the same trial processes as Western vaccines. And the surprise has been the Russian vaccine, Sputnik, which we are now hearing is 91% effective. So once we've got those candidates, they have to be tested, approved, and licensed. And the questions which you aren't going to ask, but we ought to be mindful of, is how much will it cost, and how do they reach the world's poorest populations? And finally, what about the variants that we're hearing so much about, which we can touch on if we have time?
Thanks so much, Alan. Liliana, over to you. What are the biggest challenges that the world is facing in terms of vaccination, in your view, from distribution, production, and delivery?
So I will take the Alan answer about the challenge of taking this to the poorest nations. So for me, the most difficult part as I look around the world is the developing countries. It is very hard to be ready as a nation, and we can see that in our developed countries, but for the developing world is even harder. You have to prioritize, you have to make sure you have trained your health workers, and you have to get ready all the supplies that go with it, the PPE, the syringes, the safety boxes, all of that has to be ready. So have we manufactured enough? We need to make sure that we have the adequate PPE to support the inoculation program. So I would say that supply is #1 challenge. Number 2 is timing. What is happening now is that we have a crush of demand in the first half of the year, and what it looks like, it's only most likely on the second half of the year that most of our demands will be met. So timing is a big problem and a big issue, but at the same time, it also gives countries and organizations time to plan and get ready and to build the supply chains that are needed. Also, and to end, the huge gap of the economic capacity also brings inequity between countries, and that's challenging. We saw that on the first wave of the pandemic. Many rich countries go into poor countries that were manufacturing all the PPE material, and with a lot of money, they would buy it. Rich countries snapping out huge amounts of PPE. At the end, not all the countries had access to it, and I ask myself, are we going to see that again? I'm worried that we are heading that direction, because on the top of that, there's also the logistics as well. So if you have money, you can buy the logistics. The capacity of logistics around the world is finite. The number of airplanes, ships are also used, but then there's the landlocked countries. In Africa, for example, there is around 800 million of people with no seaports. How do we get to them all the supplies? You have to combine a lot of things. It requires collective global collaboration from every possible stakeholder.
Thank you, Maria. Just extending on that, what countries do you think are being left behind in this vaccine rollout?
So absolutely, I concur with my colleagues here, Alan and Liliana. It's clear that the vaccine rollout is uneven, and that countries in the global south specifically are being left behind. So in total, we know that there's more than 100 million doses that have been given across 67 countries around the world, according to the latest data today. But if we look at a world map, the pattern is clear. There are large disparities in terms of continents and the wealthier countries compared to lower income or poor countries. To give you some figures taken from government sources by the Our World in Data project at the University of Oxford, first by continent, we see that while in North America, we've administered 5.7 doses per 100 people. Keep in mind, this is the first dose only, 2 are required. Europe's rate is 3.3. Then we see a stark decline in the other continents, with Asia at 0.9 doses per 100 people. South America's rate is 0.6, while most countries in sub-Saharan Africa have yet to start their vaccination programs. And the continent of Oceania is at the approval stages. By country level, we also see that some higher income countries are much further along in their vaccination programs compared to lower middle and lower income countries. Israel is on top of the list, having vaccinated about 37% of its population with 1 dose of the vaccine. The United Arab Emirates at 32% of its population, UK 14%, Bahrain 10%, and the US is almost at 8% as of February 1st. Then we see major disparities with countries that comprise the global majority world being left behind. Like South Africa is a perfect example. This is the worst COVID hit country in Africa, with COVID cases surging because of the new variant, the 501Y.V2 variant, and again, this country has still yet to start their vaccination program. And a lot of this, as we'll talk about, I'm sure, relates to access to these vaccines. Other countries like Brazil and South America, Seychelles Islands and Sub-Saharan Africa have begun vaccinating, yet there is no published data at this point. So the important takeaway message here is that there's uneven progress toward global herd immunity.
Thank you so much. We'll come back to questions of access in a moment, but on the issue of rollout, the governments that do have vaccines have universally been heavily criticized for poorly conceived and executed inoculation plans. So regardless of whether or not the criticism is warranted, there are major logistical and ethical challenges that come with these vaccines. And Marie, I'd like to go back to you and just ask your view on the barriers at the individual and community levels that are impeding the success of the immunization campaigns.
So I think one of the most salient barriers that impedes the success of the immunization campaigns, and it was identified ironically by the WHO as one of the top 10 global health threats in 2019 before the pandemic hit, is vaccine hesitancy. So what this means is either a refusal to vaccinate, it could be delaying vaccines. In some cases, it's using certain vaccines, but not others. In the global context, a recent published paper by Lazarus et al. In Nature Medicine surveyed almost 14,000 people in 19 countries and found that about a third of the people in that sample were not likely to take a COVID-19 vaccine. Differences in acceptance rates ranged from almost 90% in a country like China, for example, to less than 55% in Russia. And a big factor here is trust. Respondents reporting higher levels of trust in information, specifically from government sources, were far more likely to accept the vaccine. We see the same pattern here in France, where I am right now, ranging from about 46 to 60% of the population who would not get the COVID vaccine, any COVID vaccine. In the United States, a recent published paper by Mollick et al. At Yale in The Lancet found that almost again, 30% of their sample of 672 participants would not accept a COVID-19 vaccine. African-American, Latino populations, women, people under the age of 55, those with less than a college degree were all less likely to accept a vaccine compared to their counterparts. Similar results were found by the Kaiser Family Foundation COVID-19 vaccine monitor that's updated regularly. So what's contributing to this hesitancy of the COVID vaccines? We know that firstly, individuals think that the vaccines were developed too quickly, that corners were cut, and potentially this brings up vaccine safety issues for them. And keep in mind here that perceptions is what's key. So it's not the actual science or evidence that we have or will have. It really is about the perceptions that people have. And these are powerful barriers to vaccine uptake. Another worry is potential side effects, including allergic side effects or reactions to the vaccines. Among African Americans, particularly in the US context, we know that there's medical mistrust rooted in historical racist practices like the 40-year Tuskegee syphilis study, as well as racism and systemic inequities in the current medical system, as documented in research done by David Williams and his colleagues at the Harvard T.H. Chan School of Public Health. Another barrier is the disinformation we're hearing a lot about related to the COVID-19 vaccines, which of course leads to skepticism. So these are primarily the major barriers at the individual and community levels that are impeding the success of the immunization campaigns worldwide.
Thanks very much, Maria. I'd like to go to Alan and ask, how are the decisions about who to vaccinate first being made?
So basically in countries where there's socialized medicine, Canada, the UK, and many others, decisions are being made on a list is being drawn up. So in the UK, we have 9 categories that will get the vaccine. First will be those who are in residence and care homes in old age homes, residents and staff in old age homes over at 90, then those over 80, then those over 75, and it goes down. And included in that at about stage 6 is everyone with clinical conditions who are at a high risk group. In Canada, stage 1 is residents and staff of congregate living settings that provide care for seniors, then adults 70 years and older, beginning with the oldest, then healthcare workers, then adults in indigenous communities. Stage 2, healthcare workers not included in the first one, and then, interestingly enough, essential workers, and that's quite unique, that you're going to immunize police, firefighters, etc., because I don't know many other places that are doing this. Every country will make their own decisions. There's a mess in Europe about this, especially since Britain left the European Union. But those decisions are going to be made broadly at 2 extremes. The one is to save lives, and that would mean you would prioritize older people, and the other would be to save your economy, and that would mean you would prioritize your working age population. So which you're going to choose? That's the choice that we have to make.
Thanks so much. Liliana, how can public trust in science and vaccines be improved? And why, according to your research, is this important?
So I will take on Maria's point of trust and the importance of that to get to vaccines acceptance by the public. And I will go through this point through the bigger picture of it. So the fact is that over the past year, science has been in the spotlight as never before. So there is this urgent need to empower citizens to navigate this huge amount of information that are flooded with and make sense of what they hear and read and side effects of the vaccinations and so on. For example, we are talking about viruses. Viruses operate at a nanoscale, which means of billions of a meter. So imagine it's like going from one individual to the whole population in the world. That's the scale. And people engage with the idea that going to the nanoscale is something is obvious. And of course, it is not obvious. It requires new development in science. So I think that in the future, we need education everywhere, confronting people not only with the scientific facts, but at the same time with the scientific methods, so that they can understand all the things that have been achieved and make people trust more in science. Of course, to get people, we need the cognitive tools, the cognitive domain of how much can we understand about science. Only this way we can fight disinformation and biases. For example, the confirmation bias, which we have seen frequently in the past year, which means that people like to search confirmation about what they already like or know. This is why, for instance, if someone says 20 people died from the vaccines, the people follow this information against facts and do not consider the control group where people might have died in general during this time, etc. This is where science literacy makes a difference. But how can we improve science literacy? I guess three main aspects are important. The first one is the familiarity with the basic science facts. This is about understanding the world we live in, how we interact with it, and understanding our body and so on. And secondly, very important, is the understanding of the scientific method, that science is progressive, that scientists change their view, their opinion, as new facts come to light. And of course, the current pandemic has been a great illustration of it. And third, the appreciation of how science influences every part of real life, how relevant it is regardless of who and where we are.
Thank you. Very interesting about science literacy. The pandemic has also led to what many are calling now vaccine nationalism, the idea that governments should not only vaccinate their citizens first before sharing vaccines with other countries, but that the only way to protect against supply shortages is to have domestic capacity to produce the vaccines. So Alan, I want to come back to you and ask, which countries are leading on vaccine development and why?
The countries which are leading are undoubtedly the UK and the USA. Why? Because they've got a decent scientific base there. And in the case of the USA, they did amazing and very rapid work on the Ebola outbreak. So I think we're geared to working on these viruses and retroviruses, and we have scientific capacity, and long may that continue. It's very interesting because the other countries which we need to consider are Russia and China, but we're terribly snooty about those countries, and they haven't put their data out for the peer review that we would want. But I also think that they may well produce some successful vaccines, and particularly the Russian one is showing a lot of hope here.
Thank you very much. So over to you, Liliana. What is the current situation in Europe with the vaccine distribution? We're getting a lot of news here in Canada on that issue at the moment.
Yeah, well, of course, there is a huge demand right now and the race is on. So for now, 3 vaccines were approved in Europe. So the biotech Pfizer vaccine was the first approved, followed by the Moderna and more recently AstraZeneca. But if we look closely, there are already 63 vaccines in clinical trials and 173 vaccines in preclinical trials, which is a very good perspective. Hopefully, still in 2021, the vaccination campaigns will accelerate and become more fluid. The primary objective of the European Union was to vaccinate 70% of adults by the summer of 2021, by the end of the summer. But when they announced this target in January 19, the EU as a whole was injecting only 1/5 of the necessary daily doses to get there. So at this current pace, this goal will not be achieved. The only country that seems to be ahead is UK, who might achieve this goal in August 2021. Malta is the second in the table of vaccinations, and it is the only EU country in the top 4. So why is it a slow start? So there are a lot of reasons for that. One of the reasons is supply issues, and that has had impact in all EU countries. However, all these 3 main manufacturers, BioNTech, AstraZeneca, and Moderna, they announced recently, these last few days, that they would increase their delivery. BioNTech by 75 million additional doses, and the AstraZeneca by more 9 million doses, making a total of 40 million doses, which is half of the originally agreed between EU and AstraZeneca. So amid this row between AstraZeneca and the European Commission, the EU adopted a regulation to control the export of COVID vaccines that were quite discussed in the media. And they say that it's to ensure that all purchase agreements for vaccines made by EU are honored. But despite the slow pace, all countries are moving with max vaccination plans. And for example, until yesterday, Germany vaccinated more than 2 million people, which is about 2.5% of total population, and that received the first vaccination. And almost 800,000 people have already received a second vaccination.
Thank you. Very helpful statistics. The North-South divide on this issue is so stark, with rich countries in the North being accused of hoarding vaccines at the expense of poorer countries. There's a great quote by Cyril Ramaphosa, President of South Africa, and head of the chair of the African Union at the moment, who said that no one is safe until everyone is safe. Some have even called the situation a vaccine apartheid. So Liliana, can I come back to you and ask, why is it important to enable an equitable and inclusive vaccine distribution?
So I would say that vaccination to the world in an equitable and inclusive way is more than a moral imperative. And I will point to main reasons for that. There are many others. I will focus on two. So first, to get healthcare to all of us and not delay on getting herd immunity is vital. So let's say if in the poor countries, the virus circulates for years, there's the potential of the virus to mutate even more, which is something I know it is on the minds of everyone because it can compromise at least part of the efficacy of the vaccines. And the second point is that a recent study demonstrated that if the poorest nations are delayed in the vaccination program, the world could lose up to $3 trillion, and half of that loss would affect high-income countries. So it is critical to ensure that the whole world gets access to the vaccine. We cannot stop the virus from spreading. So from the humanitarian point of view, the world should have access to the vaccine, but also from the economic point of view, the access to the vaccine has to be provided.
Okay, Maria, can I come over to you and just ask what the barriers are in your mind at the individual and community levels that are impeding the success of the immunization campaigns? Then I'd like to get a bit of international context.
Sure. Since I focused a little bit on the vaccine hesitancy in terms of individual and community, I'm going to shift a little bit here and focus us on what I think are some of the major challenges in terms of the structural level challenges. So what I see as a global health researcher who studies inequities in particular, one of the biggest challenges is that there's a disconnect between how some countries are agreeing to do things in a way that shows global unity among leaders and the actual implementation of the agreement. So a perfect example of this is the COVAX facility. This is a global initiative to ensure rapid, equitable access to COVID-19 vaccines for all countries, regardless of income level. So lower income countries receive support from wealthier countries and other donors for vaccine purchases through what's known as the Advanced Market Commitment, or the AMC, to ensure that lower income countries can access the new vaccines at the same time as the middle and high income ones. However, in practice, we are seeing something completely different, which is what the WHO and public health advocates feared. Internationally, as you mentioned, we see that high income countries have adopted a competitive fend for yourself attitude, competing against others for access to supplies and commercial advantage in the COVID-19 vaccines. We see that most of the supply of the leading vaccines was pre-ordered by wealthy nations even before the safety and efficacy data was made available. So this nationalistic competition for the vaccines is a major factor contributing to the challenges we are facing in the global distribution or equitable global distribution of the COVID-19 vaccines. And this is contrary to the global interest and is likely to harm countries and citizens, again, of the global south. The pattern we see is that low-income countries with the least economic and political bargaining power have less access to the vaccines.
Thank you very much. Alan, I want to come to you and ask you about, you do a lot of work in South Africa, you do a lot of work in that whole South African cone. What will happen, in your view, to the poorer countries and in the poorer countries where it seems that there is significantly less access?
Let me begin by responding to something that one of my colleagues said earlier when they were excusing South Africa. Let's be clear, South Africa is being corrupt, inefficient, and politically inept when it comes to accessing and delivering vaccines. And I can say that because I'm a South African and watching what they're doing with absolute shock and horror. My government sucks at this moment on the COVID response. Leaving that little rant aside, The question, I think, is being posed in a wrong way, and I think the answer is more complicated than we're talking about. I really don't believe that we have to get the world vaccinated immediately. I think what we have to do is we have to identify the priority groups, which are those who are most likely to suffer ill effects or most likely to transmit the virus to others, and those are the people that we should be targeting. The number we should be looking at is the R number and how it's coming down, rather than trying to roll out. This idea that vaccinate one, have to vaccinate all is just not acceptable. It can't happen, and I think we need to start prioritizing in a realistic manner, and that has to be done on health, ethical, and economic grounds.
So Maria, would you recommend, is there a one-size-fits-all approach for getting everybody immunized at the global level?
So I think that a one-size-fits-all approach is not the way to move forward to getting everyone immunized. We do need tailored responses. First, the needs are going to change. They're going to ebb and flow. So we need to have both global and national plans that are flexible in their implementation at the local levels through community mobilization. We need to listen to people on the ground, the vaccinators, the community members, other local actors, to understand what is happening and the barriers that are preventing people from getting immunized so that we can respond accordingly. There are lessons we can draw from the Ebola virus vaccine, epidemic in West Africa in 2014-2016. My colleagues at American University, Nina Yamanis, Elizabeth Nolan, and Susan Shepler did field research in Sierra Leone during the outbreak, which showed that the Ebola response system was hampered because we did not have those local perspectives and the fears and perceptions that were related to a lack of trust in the response systems. So we need to take into account the barriers and cultural perceptions of different communities to design and implement effective health campaigns. Second, we need to especially focus on communities and segments of the population that are hesitant about vaccine uptake. I'll draw from my own research here related to the human papillomavirus, or the HPV vaccine, when it first came to market in the United States in 2006 for use among 9 to 26-year-old females. There was a lot of vaccine hesitancy, especially among Latino and African communities. What my research showed was that there was a large discrepancy between the actual and preferred sources of HPV information in the communities. They wanted the messengers to be trusted sources of health information, and in this case, it was a health provider, rather than the pharmaceutical and media campaigns. So we need to have a right message, right messenger approach to learn who are the most effective and trusted messengers and influencers, and tailored clear messages to ensure that they resonate with the target audiences and enhance trust. So the takeaway message is clear here. We need to take a science-informed approach, as Liliana was mentioning earlier. However, we need to know that science doesn't have all the answers. Certainly in the case with COVID, we see that we're learning as we go here. We don't have everything we need when we need it with science. So this is where I think art needs science to ensure this effective tailored communication response and the implementation is provided rather than a one-size-fits-all approach.
Thank you. Let's talk about this variant, this second variant. The recent UK, South African, Brazilian second variants of coronavirus just reinforce how much it is, much in our collective self-interest it is to have a vaccinated world. But effective international cooperation is easier said than done. And we're not even hearing much about rooting things through the World Health Organization as much as we were on the lead up to this vaccine development phase. Liliana, what are the organizations that have a crucial role in the delivery of vaccines to the developing world?
So of course, this international cooperation between different organizations is very challenging, of course, and difficult to get. I would start, as Maria said, she already mentioned COVAX, which is one of the 3 pillars of the ACT accelerator. So it's the Access to COVID-19 Tools Accelerator that brings together governments, global health organizations, manufacturers, scientists, private sector, civil society, and so on. And it's supported by the World Economic Forum and coordinated by WHO in partnership with Gavi, CEPI, and so on. And so far, 190 countries have signed up. But when you talk about organizations, we have to go to maybe to the organization that has a long history in vaccine distribution, which is UNICEF. So UNICEF for the past 30 years has been the largest single buyer of vaccines in the world. Every year they buy 2 billion vaccines, and this year they are planning to double that number. And currently they are distributing to 100 countries. So this is massive for an organization. It has to have partnership. It's very important, the agreement with the supply companies that enables them to move the vaccines to every corner of the world fast and safely. In addition, these types of organizations, they have to move the vaccines that help, and also help the countries in the readiness, in their own readiness, which mean training of the health workers, the strength of the supply chains, and talking with the populations about the importance of getting the vaccine so that there's no hesitancy by the public. So, of course, there are many partners to accomplish this. UNICEF, for example, is in partnership with Gavi. They are buying, for example, refrigerators to help the cold chain, because these initial vaccines, they are for once quite expensive, and they have this thing of they need to be stored in ultra cold temperature, so they are not easy to use globally. Of course they can be used globally, but it is just harder and takes additional work and investment. Hopefully the new generation of vaccines that are coming will be easier to flow around the world. So
Maria, Liliana's just named off a lot of organizations that have an interest in this area that we as nations should be able to network to get that vaccine distributed across the world at a faster pace. What recommendations would you provide to ensure that the maximum number of people are vaccinated around the globe?
So I would say three things in terms of ensuring that the maximum number of people are vaccinated. First, we need to adopt an attitude, an approach, actions that reflect global fairness, solidarity, and equity for the timely vaccine distribution and immunization campaigns across the globe, so that there is not discrepancy between our words and our actions. As the WHO director stated, that richer countries helping poorer countries is not charity. This recommendation also resonates with your earlier quote by the president of South Africa, who recently said that no one is safe until everyone is safe. So we risk exacerbating more inequities in infection or mortality rates. Second, we need local, national, regional, and international coordination of the vaccination rollout. As Liliana mentioned just a few minutes ago, we already have an established mechanism to do this, known as the Access to COVID-19 Tools, or ACT Accelerator, which is a partnership launched by WHO and other partners to support this coordinated and global effort. And third, to control the pandemic, we need both a top-down and bottom-up approach. We need strong commitment, cooperation, and implementation of plans among our scientific, our industrial, and political leaders, in conjunction with community mobilization, as I mentioned earlier, at the local levels. So the important message driving these recommendations is that we see the COVID-19 pandemic has an impact on a global scale. And so logically, we do need a global response rather than one region at a time or high-income countries before all others to effectively control the pandemic.
Thank you. Alan, I want to come to you and ask you, when vaccines have been rolled out, what sort of normality should we expect? Will things return to normal?
Mm-hmm. That's a very good question. I think the answer is we'll return to a sort of medical normality where life of travel and that sort of thing will be possible, but it will require us to carry some sort of proof that we either have been vaccinated or we've had a recent COVID test. And that's going to be where if you cross when you cross a border, border plane, or access a service. I think we're going to have a proof of health, so to speak, which is not unusual, let me say. And I'm just going to reach over and flash my yellow fever card, which many people will recognize, which we all have to carry. So that normality, yes. Economically, no. We are in deep, deep trouble, and it's going to continue for a very long time. It's going to affect government budgets, and it's going to affect our own pockets. I think many of us on this call are the lucky ones because we're in secure employment, and that is not the situation for the majority of people. Where I live in Norwich, on the tarmac of the airport, 10 minutes away from my home, there are 25 planes sitting there, and I don't believe many of them will fly again.
Gosh, okay, well, let's turn to some of the questions in the audience, some questions that have been rolling in. Maria, can I ask you this first question from Paul Cadario? Countries are getting vaccinated or giving vaccinated citizens proof of vaccination on cards, similar to the one that Alan just held up, or electronically, for example, US CDC. Will these records help with travel and border controls without quarantine? Surely this is part of restarting the global economy.
Yeah, I mean, I think it certainly would in terms of providing actual evidence and incentivize, really more than anything, people to actually get the vaccine in light of all the barriers we talked about related to vaccine hesitancy. So I think, you know, if people, to go back to your earlier question related to normality, if they want to get anywhere close to normal, which, you know, at this point, I don't even know what that is, but certainly to be able to travel freely, I think we have to incentivize people to vaccinate, because vaccination is not simply for oneself, it's for others as well. It's protection of others and, you know, trying to reduce spread. So it's that both individual level, but also collective level responsibility.
Thank you. Alan, there's another question on, I think it's intellectual property, IP. The question is, please comment on the debate about the suspension of vaccine IP during the pandemic so that the Global South can have greater access. Any insight?
Yeah, the intellectual property is an interesting point. The problem is that with a vaccine, you have to manufacture to such high standards, and you have to have a track record before you can do it. So in most countries, that isn't even an option. You're not going to get a Kenyan vaccine or even well, you probably would get a Nigerian vaccine, but you wouldn't get one to the high standards that are required internationally, and certainly not one that UNICEF would buy. So we're unlikely to see manufacturing happening in the global south, and it's not because of IP, it's because of not having a track record. South Africa, which is a highly scientifically advanced country, which may well be involved in producing and testing and trialing vaccines. In fact, I know we have been. We're not setting up vaccine manufacturing, but we are setting up packaging plants, and we would be prepared to do that. The only countries which can in the global south are China and India, and I'm surprised that India hasn't yet entered this area to the extent it would. But I suspect what will happen is it will be licensed to produce vaccines by one of the people who've developed it.
Thank you. And Alan, while you're on, we've had a student from the US who is a South African student express his appreciation to you for your honesty about the Republic of South Africa. He does have a question specifically about that case, which is, where did RSA go wrong with the vaccines, and what is the way forward, in your opinion, for the country?
I think the place we went wrong is we spent too long debating over the epidemic and what was causing it and where it was going. And there was an unseemly spat between Cyril Ramaphosa and senior government people and Glenda Gray, who's a distinguished virologist, about this. And there was harking back to the denialism of the AIDS time. Governments need to be nimble, quick, change direction and apply resources. South Africa was unable to do that when this epidemic broke in our society. And with some fairness, they just didn't want to believe it was happening, as we all do. This is a nightmare. Wake me up in 2023.
Liliana, question about If we don't see better international cooperation, what is the worst case scenario in your view?
So I would say that if we don't see that, so for example, the developing countries will suffer much more with this pandemic in long-term consequences, not only on health, social, but economically, if this international cooperation is not seen. And we still don't know if that hopefully will happen, but this is a very challenging scenario. So I think that they would be the ones that will suffer more longer consequences along the time.
Maria, the question, could you comment on how government communication impacts vaccine hesitancy? For example, healthcare workers in Ontario here were told after the first dose that they would receive the second dose within 21 days based on scientific recommendation, but were later told that they would have to wait to get a second dose within 42 days. Surely news of these changing policies would result in hesitancy.
Yeah, absolutely. And that's a really good example. And this will happen, I think, more often than not, precisely because of some of the points that Alan made earlier, related to distribution and all the difficulties with keeping pace. And so I think the way to respond to that is to stay nimble, be flexible. You know, there will be ebbs and flows. On the ground, things will change both locally, nationally, internationally. And so we have to sort of keep pace with those changes and be able to respond accordingly very quickly. I think consistent messaging and clear, transparent messaging is the way forward when it comes to making sure that we don't hamper the trust, both in our scientific leaders, our political leaders, and everyone else. I mean, it really is about consistent, clear, transparent messaging. We have to be forthright about the fact that this is mammoth of a challenge that we have before us, and it will take a lot of coordination. We hear examples, for instance, about needle shortages in Europe and, you know, the lack of vaccinators, right? Like nurses to be able to vaccinate. So we need to quickly train people to be able to do this. Who's able to do this? Can we loosen up or, sort of make the regulations a little easier so that new vaccinators can come onto the scene? So everything, and then everything else, right, with distribution in terms of some of the logistical challenges that Liliana brought up earlier. So I think, again, to keep trust and to make sure we have a collective response, both top down and bottom up, is honesty and transparency. We have to be clear with everyone.
Thanks very much. Alan, question for you. How will governments use COVID as a scapegoat or an excuse for politically motivated maneuvers going forward? Will it be used as an excuse, for example, to practice trade, immigration, social policies, etc., practices that are otherwise deemed by some to be illegal or immoral?
Undoubtedly. I haven't seen it yet, but we're certain to start seeing it soon. I think this is an example of a pandemic which should have brought the world together, but may well fracture us into the future. As we see with vaccines, people look out for their own populations first. But I just want to pick up on this question of messaging. I think the one thing which governments have been really bad at doing, and they shouldn't be bad at it, because as an economist, I live by the Keynes' saying, when the facts change, I change my mind. The message governments should give is we don't know. There are things we don't know. The messages will change. An example which you may or may not be aware of, you're probably not aware of it because it's a message which has slid out of the public domain, is the importance of not touching surfaces and touching your face. That's no longer as front and center as it used to be, because there's evidence that fomite transmission isn't as serious as we had originally thought.
Liliana, question about the death projections that Dr. Fauci in the US has predicted, and that is that the US will see close to 600,000 deaths before the curve starts to come down. What are the world's death projections? Have you got any insights on what is yet to come despite this vaccine rollout?
Well, currently the facts are happening so fast, and all these statistics change so fast that we are on the basis of seems to be. So I actually don't know what are currently the world's death projections. So this is difficult. It's really difficult to predict all these types of statistics, because we have to calculate based on the conditions that are happening now, based on the infection rate that is happening now. So we still don't know that if this still is going to go down, if all the impact of vaccination in the population and the continuity of all these preventive measures, that are fortunately much more embed in our lives. So it's much normal using a mask, at least in Europe. So it's very normal to use a mask every day in public settings and indoors. So these types of measures, of course, they have a huge impact, and the vaccination also. So I don't know actually what are the world's death projections currently.
Thank you very much. I've got a question coming in on a private chat here. Gendered inequalities. Maria, would you like to say anything about EDI or the intersection of global justice and social equality and vaccine rollout? Are we seeing any concerning trends that are not sort of gender-based plus compliant in your view?
Well, we do see in terms of that, I'm not clear on the question, but in terms of vaccine hesitancy, if that's the question related to gender, we do see that women in particular tend to be more hesitant about getting vaccinated than men in general, and that's globally. What was the second part of that question, Anne?
No, it's just that, you know, in the wake of concerns about anti-oppression and equity and the need to practice diversity in all we do, are there any areas that cause you concern at the moment?
Well, I think, again, it's going to require a consistent messaging from trusted community influencers and leaders in particular communities, especially, as I mentioned, in communities that have been have been victims, if you will, of racist practices, medical practices, and have historical evidence where these practices did more harm than good in these communities. And so I think it's going to be important, once again, to make sure the message is about this is a collective response that's needed. And we need to get in touch with what the fears and misperceptions and mis and disinformation is, so that we can address those concerns. And some of those concerns will have to be tailored, certainly to certain communities. I mentioned the African American community earlier, Latino communities worried about immigration policies. You know, if I go get vaccinated, will some of this information then be transmitted to the government? If I'm undocumented, I have all sorts of worries. Migrant populations have worries, especially as, you know, Alan was mentioning, governments seem to be prioritizing their own citizens. So there are all these concerns, I think, that people have, and rightly so. And I think it's going to really take, again, major trusted leadership, and that might look different in different communities, to make sure those messages are clear and honest and transparent.
Okay, Liliana, there's a question about whether or not we have seen, any of you have seen, of any evidence of vaccine results in children so far. Obviously, children are not, the healthy children are not the priority category at the moment, but can you offer any insights there?
So as far as I know, the vaccines that are being developed right now are not for children, are only for adults. So because this was based in many epidemiological data that children were not that transmissible. So maybe with these new variants, what we have seen, for instance, this new so-called British variant and South African, there are more children that are being infected. Maybe in the future this will change, but currently the vaccines, as far as I know, that are being developed are not being addressed for children.
Thank you. Alan, questions about this tension between getting kids back to school, and the economic implications of this, both for stay-at-home parents trying to homeschool and keep their jobs up, and also building our future leaders and our future knowledge base. So this puts teachers really front and center into that essential working category. Any views on this? And because this, as you brought up in the response to one of the questions, is being treated in a variable way across the country, across the world.
Well, I have a personal interest in this as well, because my sister is a nursery school head in London, and they have not shut. And that means those teachers are vulnerable. So I would argue that if you want to get children back to school, then inoculating teachers should be a priority. We have a list of 9 categories. I think we ought to put teachers on it, include them as essential workers, and move them up the list so we can get kids back to school. Because frankly, the one thing which we've not talked about is the impact of this epidemic on the next generation, which is truly, truly frightful. And just before I hand over the mic, Anne, just for your information, folks, one of our senior scientists in England said, well, at the beginning of the epidemic, said, well, we'd be lucky to get away with 20,000 deaths. Well, we're at 110 and counting.
Right. Well, on to policy recommendations for those policymakers, especially those that are tuned into our session today. Can I just do a quick tour de table, starting with Liliana, and ask each of the panelists, what are the top recommendations you would leave with the policy world?
So firstly, COVID-19 affects developed and developing countries and requires global cooperation and solidarity. The other one in forms of the development assistance. And this is the baseline of the problem in developing countries, which is the gigantic lack of investment since ever. And the second one, I would say that for a sustainable world and for the upcoming struggles we would face in the future, science should remain center stage, even in non-crisis periods. And to get that, the binding from the wider society and building trust is crucial, and therefore public understanding and engagement with science should be improved and taken into consideration by policymakers.
Thanks very much. Alan, very quickly, what's your top tip to the policy world?
My top tip to the policy world is do something you used to do. I've done a lot of times, and that is scenario planning. That is a tool which would allow you to look into a future which is so uncertain and come up with perhaps not answers, but at least some directions to move in.
Thank you very much. Maria, finish us off.
So I'll just say I agree with what's been said so far by my colleagues. I would just add that our policies need to be driven by an imperative of global equity. And to do this, we need ultimately to have the will and the bold ambition to translate the policies into action.
Thank you very much. Thanks to all 3 of you. I learned a great deal today. Keep up all the great research that you're doing on this subject. Thank you to the audience. I hope you will join us again next week, same time, same day, and same link, for a look at steps towards a lasting peace in the Middle East. Until then, thanks very much. Take care and stay safe.